So, without further ado, I'm going to launch into the first talk about what many of us now consider an orphan disease, except this particular orphan has very specific therapies that have emerged in the last year, and that's specifically squamous cell carcinoma of the lung and how to individualize therapy. My disclosures are shown here. I've been accused of pharmaceutical promiscuity, and this is proof of that fact. So again, just by background, lung cancer is unfortunately the most common cause of lung cancer death in the U.S., over a quarter of all cancer deaths, more than breast, colon, prostate combined. In the last 10 years, we've seen a jump in the incidence, in part because of screening, but at least 220,000 new cases a year with over 160,000 deaths. And this is largely due to the unfavorable stage distribution at the time of diagnosis. 50% or more lung cancer patients are diagnosed with advanced disease. 7 out of 8 will have non-small cell. Only about a third of these are squamous. And small cell is a diminishing portion of the pie, down from 20% 30 years ago to 13 to 15%. And here again is the pie shown through ISLAC data, so many thousands of patients accrued to this. And you can see of the total, squamous cell is roughly a quarter of all lung cancer diagnoses. It's important to review histology, and this is one of the few talks that actually has histographs. Again, adenocarcinoma characterized by a glandular pattern, mucin positive in about 50%, often CK7 positive, TTF1 positive, thyroid transcription factor. So in the absence of an elevated thyroglobulin, obvious thyroid mass, TTF1 positive tumor in the chest is almost always lung cancer, particularly if the lesion is spiculated. Squamous cell characterized by cellular keratinization. You can see some of these pink keratin pearls, intracellular bridging. Unlike adenocarcinoma, CK7 negative, TTF1 negative by and large, and positive for either P40 or P63. So if you have limited tissue, the two most important immunohistochemical stains are the P40-63 and TTF1. Squamous, again, more central presentation, higher incidence of local regional recurrence, less likely to spread metastatic, although that certainly happens almost as often as adeno, relatively more common in men, Eastern Europe, and amongst smokers, and the incidence may be declining overall. Adenocarcinoma, more often peripheral, higher incidence of metastatic spread, less profound link with tobacco use, although still well linked with the history of cigarette smoking, and increased incidence and relatively more common in women than men. And there was certainly a tendency, at least up until about 12, 15 years ago, to lump all non-small cell histologies together. There was very little difference in therapeutic outcome. There was a tendency toward therapeutic empiricism. From the 60s through the 90s, we saw this increased use of the NOS, not otherwise specified designation, in part because we were relying on relatively little tissue, fine needle aspirates, and in part due to pathologic laziness on the part of pathologists. I apologize to any pathologists who might be here, but it really wasn't necessary. We had studies of this sort. Suresh Ramalingam and I participated in this. You see absolutely no difference in therapeutic outcome, regardless of which combination used. And frankly, these outcomes were independent of histology. So really, the pathologist's work was done once they distinguished small cell from non-small cell. In the last decade, things have changed. We've seen the advent of histologic and molecular fingerprints. They've become ascendant. Treatment restrictions and risk-based approaches of bevacizumab, for instance, restricted to adeno because of high risk of hemoptysis and squames. Histologic variations in outcome, again, adeno better outcomes with the TKIs and pemetrexed, and it's really largely the province of actionable molecular markers, as you'll hear shortly. But even squamous, we are starting to see distinct trends. Gemcitabine has shown superiority to pemetrexed. NABPAC compared to standard Q3-week solvent-based paclitaxel has a higher response rate in squame. EGFR monoclonal antibodies, particularly necitumab, which was presented just last year, showing a survival advantage. The immunologic approaches, phase 2 data for IPI with PAC-carbo compared to IPI, chemo alone, which has shown promise and has led to a ongoing phase 3. And of course, the approval just last week of nivolumab in second-line squamous compared to, based on survival benefit compared to docetaxel. We've also seen the emergence of angiogenesis inhibition in squamous with ramucirumab and docetaxel yielding a better survival rate than chemo alone in the second line. And finally, the emergence of potential molecular targets, including fibroblast growth factor receptor and PI3 kinase, although these are still investigational. I'll explore these during the talk. So again, up until very recently, squamous was the wallflower at the dance, in part because of safety signals, lack of efficacy or less efficacy with PEM, and the lack of actionable molecular markers. The original randomized phase 2 trial of bevacizumab included squamous. Remember, this was 2 different doses of bev with chemo versus chemo alone. And it was this experience with 6 cases of severe fatal pulmonary hemorrhage, 4 of which were in the squamous cohort, over 30% of squamous patients, that led to the exclusion of patients with squamous histology from subsequent trials, and that exclusion has held up ever since. So the PFS and OS advantages shown here in the phase 3 trial were limited to non-squamous histology. And then what I consider the ultimate in corporate opportunism, PEMCIS versus GEMCIS, a company comparing their older drug to a newer drug, in this case PEM, which would recently been approved in second line. Fortunately, Giorgio Scagliotti had the foresight to examine this trial based on pre-specified histology, postulating that those with lower TS levels might be more sensitive to pemetrexed, and that was largely the province of adenocarcinoma. So, frankly, if I had been the CEO of Lilly, I would have done the same trial, over 1,700 patients, no difference in overall survival, but as vindication of Scagliotti's hypothesis, a survival benefit in the subgroup with non-squamous histology, so adeno or large cell, favoring PEM over gemcitabine. And in secondary analysis, the same trend had been shown, non-squamous group showing an advantage for PEM versus docetaxel in the second-line trial, comparing these 2 agents head-to-head that was originally published by Nasser Hanna. And we've seen this extend further to the maintenance setting with pemetrexed benefits, both PFS and overall survival, exclusive to the non-squamous cohort in the switch maintenance trial. So pemetrexed, ironically, squames lost the indication for pemetrexed based on this body of work. These disappointments certainly didn't prevent us from targeting squamous patients in either recent or ongoing empiric trials. This is a trial that was through the Eastern Cooperative Oncology Group, looking at PAC-carbo with either cetuximab, A12 IGFR inhibitor, or the 4-drug combination. The reason you haven't heard about it is it stopped early, suspended because of untoward toxicity, intriguingly in the cetuximab arms, including a higher rate of grade 5 toxicities. And then certainly interest in looking at the multi-targeted TKIs, so sorafenib with PAC-carbo, the ESCAPE trial that was essentially agnostic to histology, so both squamous and non-squamous were included. And here we actually see a survival decrement in the squamous group. No benefit in the non-squamous, but at least no decrement, but about a 4.5-month drop-off in median survival for the squamous cohort compared to the placebo. So you were hastening patient's death by adding sorafenib. And finally, a study I was intimately involved with that looked really promising and randomized first in phase 1 and then randomized phase 2, adding fiduciumab, an IGFR inhibitor to PAC-carbo. PFS was superior compared to PAC-carbo alone, but here too we see a borderline significant reduction in survival for the fiduciumab arm compared to chemo alone, about a 2-month drop-off. So major disappointment. Is there any hope? Well, in the next 15 minutes, I think I'm going to at least show you that we are making headway. This is the unanticipated outcome of the Scagliotti trial. GEMCIS versus PEMCIS. There was no hypothesis that would necessarily lead to anyone concluding that GEM would actually be better than PEM in the squamous group, but it's almost the reciprocal of the non-squamous group. Hazard ratio 1.23, you see separation around the median, and because of this, even though it was really hypothesis generating, many of us have used GEM preferentially in this category. And if you look at the squamous group in the randomized phase 2, the taxanes actually fare better than pemetrexed in the second-line setting. So again, suggestion perhaps that taxanes have equal billing in the treatment of squamous histology. And then nanoparticle albumin-bound paclitaxel given weekly with carbo compared to a Q3-week carbo regimen, a more conventional regimen. Here, too, we see at least a response rate advantage, about a 65% improvement in response for the weekly approach with NAB-PAC compared to conventional solvent-based. You do not see any response difference in the non-squamous histology. This did not translate into either a PFS or overall survival advantage, as shown here. But at least in the elderly, and again, this is a post-hoc analysis, we see about a 9.5-month difference in survival favoring the NAB-PAC approach. Now, is this the schedule, which is weekly compared to the Q3 week, or is it the actual drug? That remains to be seen, and that's actually being investigated prospectively. We also see less neuropathy with the weekly approach, as shown here. These are the FACT taxane scores. Monoclonal antibodies targeting EGFR. FLEX trial looked at venoral being cisplat with or without cetuximab, a huge trial, over 1,100 patients, actually made it to the plenary session at ASCO about 7 years ago. Survival benefits, statistically significant, clinically modest, but you can see here that the benefits were observed in both adenocarcinoma and squamous cell. In fact, the hazard ratio for squamous was a little bit lower than the adeno group, and that really laid the groundwork for a squamous-specific trial called SQUIRE, which was just presented last year at ASCO, looking at a second-generation EGFR antibody, necitumumab, with GemCis versus GemCis alone. This trial included PS2. It was global. You see a statistically significant, clinically modest, but real survival advantage, about a 5% improvement at 1 year, about a 3.5% improvement at 2 years, but a p-value of 0.012. So again, as mentioned yesterday, that means 99 times out of 100, this result would have been real. And this was seen across the board, regardless of gender, ethnic background, smoking status, performance status. The only group, intriguingly, that doesn't seem to benefit much, and there are limited numbers, only about 200 patients, were those over 70. More hypomagnesemia, more skin rash, as we'd expect with this type of drug. This drug has been engineered to avoid hypersensitivity reactions, so we don't see any major difference there. Bit more conjunctivitis, and intriguingly, no difference really in thromboembolic events. So this is a slide courtesy Ram that he used, or Julie Bramer actually, but I think Ram's used it as well, comparing SQUIRE versus FLEX. So essentially the same study design, chemo plus or minus monoclonal antibody, both positive, at least statistically. You see a bit more separation early on in the SQUIRE trial, which is squamous exclusively favoring the necitumumab arm, and also a PFS benefit. So statistically significant, acceptable toxicity profile. An analogous trial in non-squamous, largely adeno, looking at PEMCIS with or without necitumumab, showed no survival benefit and actually had an untreated incidence of thromboembolism. Ramucirumab, which you'll hear a bit more about from Ram, is a recombinant human IG1 monoclonal that binds with the extracellular domain of the VEGF-R2, so it's different from Bev, which works on the ligand. This is the Ravel trial, again, presented just this past year at ASCO. Docetaxel plus or minus RAM, placebo-controlled. Over a quarter of patients accrued to this trial had squamous histology, and you see, again, a statistically significant improvement in median survival, which is heralded actually by improvements in both response rate and progression-free survival. And here's the breakdown by histology. I actually have to go to the paper, which was just published by Eddie Guerin in Lancet, to find these data. And as we've all come to expect now, adenos do better, but the relative benefits are seen in both histologies, the HR of 0.88 for the squamous group. Unlike bevacizumab, at least in the second, here in the second-line setting, there's no difference in grade 5 events or major pulmonary hemorrhages. You do see more febrile neutropenia and a little bit more fatigue. And here again are the survival curves. So this trial is distinct in that it's the first study in second-line advanced non-small cell setting to show any survival advantage. We actually have a second one, which I'll talk about shortly, and the first study of angiogenesis inhibition in advanced non-small cell to benefit squamous histology. Well, most of the recent action, of course, has been with immunotherapy. But the PD-1 and PD-L1 inhibitors were not the first to be evaluated in squamous cell, or for that matter, all non-small cell. This is a study by Tom Lynch and colleagues looking at PAC-carbo combined either alone or combined with IPI given day 1, so first cycle, or delayed or phased to cycle 3. And you see a 4-month survival difference favoring the phased approach. And if you look at these forest plots, granted relatively small numbers, only about 35 patients, the survival benefit is particularly pronounced for the squamous cohort. Hazard ratio here is 0.48. And here are the actual survival curves, so about a 3-month difference for the phased approach compared to the controlled approach. Control approach with PAC-carbo alone. So this has laid the groundwork for a major prospective phase 3 trial comparing PAC-carbo alone to PAC-carbo combined with IPI in squamous only. This trial, I believe, is still ongoing or maybe down the home stretch. It's taken several years to accrue, but stay tuned. The first-line evaluation, squamous specific, of immune therapy. We've talked repeatedly at this conference about the PD-1 and PD-L1 inhibitors, so I'm not going to review the mechanism of action. You'll hear a little bit more about that probably from Govardhan. But you can see that Nivo has been tested in lung cancer. There seems to be a dose threshold at 3 mg per kg with response rates over 20%. These are generally heavily pretreated patients, although good performance status. 1-year survival rate rivaling what we had seen historically, over 40%, 2-year survival rate of 24%. And you can see the response rates are very similar regardless of histology. So 22, 24% for squamous, 26 and 18% at the 2 major doses for non-squamous. This is just an example of a patient who had been heavily pretreated, 4 separate prior lines for stage 4 disease, ex-smoker with squamous cell, big right upper lobe mass that's nearly resolved, a pericardial mass that's improved as well, adrenal mets and liver mets that have shrunk nicely after just a few cycles of Nivo, and the response we hear is ongoing. This led to a phase 2 trial led by Ram, who's actually going to talk about adeno, but this was refractory squamous non-small cell, 2 or more prior systemic therapies. Correct me if I'm wrong, Ram, but the median was 3 prior therapies. Standard dose, 3 mg per kg every 2 weeks until disease progression or unacceptable toxicity, and response rate was actually the primary endpoint. So 15%. Doesn't sound great, but this is 4th-line treatment. There is no cytotoxic I know of has ever crested above 10% in this category, and really no indicated drug in this setting. The overall disease control rate, whether we look at the independent radiographic review or RESIST 1.1, 40 or 47%, a lot of correlation, excellent concordance between the independent radiographic review and investigators, which really calls into question the whole need for doing this very expensive, labor-intensive external reviews. The waterfall plots, a minority, but a sizable minority of patients, 8 of whom had partial response in the setting of rapid disease progression. So really, those folks are generally heading straight toward hospice. And these are called spider plots. We've seen swimmer's plots. We have all sorts of plots these days. But you can see many of these are quite durable, including several with stable disease, and CNS penetration. So a patient who had a small brain met that had not required CNS-directed RT, it's actually shrinking on this therapy. PD-L1 status may be slightly higher response rates, but not much. You still see responses in individuals whose tumors have no PD-L1 staining. And as time goes on, I think we're going to call into question more and more the necessity of doing IHCs for PD-L1. Here are the survival curves, median survival of 8 months, 1 year overall survival, just over 40%, virtually matching the phase 1 data, and relatively little toxicity. And Beth will talk about that in a little bit more detail, but only 17% with any grade 3 or 4 toxicity. So remember, this newer generation, PD-1 and PD-L1 inhibitors are relatively less toxic than the CTLA-4 inhibitors, radically so. So safe, can be done outpatient, durable clinical benefit. The preliminary data correlating PD-L1 expression with response I would call into question, although it's still being looked at prospectively. And these results, needless to say, have led to clinical trials of Nivo in squamous, but also virtually every other venue in advanced non-small cell, one of which we just heard about was positive. This is one of the checkmate trials, phase 3 of Nivo compared to docetaxel, second-line, advanced squamous specifically. Primary endpoints were both response rate and overall survival. And I call this a stealth press release. It was on a Sunday night. I emailed Ram and I said, I can't believe they're releasing this on probably the least active time that anybody would pay attention in the media. But just 2 months ago, we heard it was positive. We hadn't seen any data. And just last week, it got approved. And this is straight from the package insert. This is a major separation in survival. We see a 3-month improvement in median survival compared to conventional full-dose docetaxel. And these are the patients we see. 76% were male. Most had good PS. Median age was 63. One hardy soul at 85 being randomized to docetaxel versus Nivo. 93% Caucasian. But that separation occurs early, and it persists and actually expands over time. So I imagine we'll see more data at ASCO. Ram and I were debating this because they've already revealed the data. Would ASCO embargo it? But we have not seen response data. We have not seen PFS data. We haven't seen the rate of crossover to chemo in the Nivo arm, and some of that benefit may be due to that crossover and perhaps enhanced responses. I'm going to finish up with actionable targets. Lung cancer, as you're about to hear, there are a lot. You're all aware of them, including EGFR, ALK, and ROS1. Squam is really lagging behind. As of 2010, we really did not know how to slice up the pie, but in the last year or two, about 50% have been characterized. Many of these overlap, but FGFR amplification, PI3 kinase mutations, PTEN loss, and this has led to a major study which is available throughout the country, the Master Lung Protocol, squamous second line, that essentially gets an a molecular profile on patients based on tissue, and depending on the biomarker, individuals are assigned to a particular cohort in this study. So chemo compared to FGFR inhibitor, CDK4/6 inhibitor, PI3 kinase inhibitor, HDF versus erlotinib, and you can see some of the candidate agents. Some of these have actually closed. And then a biomarker non-match arm looking at the MedImmune PD-L1 inhibitor, and already this arm is outmoded. With the approval of Nivo, most of us would argue that this arm probably needs to be reconfigured, and frankly, the control arms are also outmoded since Nivo is better. So this trial, in all likelihood, based on a conference call this past week, will turn into a third-line trial, because what do we do after Nivo? The question still exists, is it chemo or molecular marker, and perhaps some immune combination for the biomarker unselected. I'm going to finish up with maintenance therapy and advanced squamous. The JMEN data, of course, restricted availability of PEM to non-squamous, so the Paramount trial was exclusively non-squamous. The benefits seen here with maintenance treatment, both PFS and overall survival, do not apply to squamous histology. But there are other trials. Docetaxel has been looked at in this setting. This was immediate docetaxel versus a more standard delayed second-line docetaxel with patients randomized specifically to that arm, not chemo du jour. And you see here a significant PFS benefit, a trend toward improved overall survival benefit, and this included squamous patients. Again, this is not indicated formally for second-line maintenance, but at least some benefit. Erlotinib is indicated in maintenance. This was the Saturn trial, 4 cycles of platinum-based chemo. In the absence of progression or toxicity, individuals were randomized to erlotinib versus placebo, again, independent of histology. And you see, again, a PFS benefit and an overall survival benefit. And if you go to the paper published in Lancet in 2010, at least in those who were stable initially before they were randomized, the hazard ratio here for squamous is 0.67. Very few of us use erlotinib as maintenance, but this is a real survival benefit in that realm. NABPAC is being looked at actively here. This is a Phase 3 trial comparing NABPAC to best supportive care in individuals who have stabilized or responded to weekly NABPAC and carbo, 4 cycles, the 2-to-1 randomization. The trial's ongoing. So what do I do for squamous cell? Well, first-line carbo and a taxane. Lately, I've been favoring weekly NABPAC, usually a 3-week out of 4 schedule, particularly in the elderly. Carbo-gem is reasonable. Pemetrexed, of course, is contraindicated. Maintenance, PEM is contraindicated. Erlotinib we tend to use rarely, although perhaps we should use it a bit more often. I'll usually observe, at least off study, or consider gemcitabine. Second line, until very recently, our only options were docetaxel or erlotinib, and now we have 2 more options, docetaxel and ramucirumab, and the one I think most of us will be going to, nivolumab. So I'll end here right on time.